Good morning, good afternoon, good evening from wherever you are in the globe. Welcome to the Essential Tools for CTO-PCI, brought to you by BrosMed. My name is Kalpa De Silva. I'm an interventional cardiologist at St Thomas' Hospital in London. I have been asked to moderate today's webinar, which is a great privilege. I've been joined by my colleague Mihajlo Kovacic from Croatia, who is the head of the department and CTO specialist, and you may well have seen his very well-versed book on CTO Toolbox, which is now a global hit. Over to you, Mihajlo.
Hello to everybody. It's my great pleasure to be on this meeting to Essential Tools for CTO-PCI, where we will, I'm sure, hear some very interesting cases and topics, and also it's a great pleasure to be co-moderator with my colleague, Dr. Kalpa De Silva, consultant interventional cardiologist from St Thomas' Hospital in London. So again, hoping for the great cases and discussion. So I think we can start with that.
Excellent. Yeah. So as we've got a relatively short time scale, I'm going to get straight on. I'll just introduce the three guest speakers, fairly global. Today we've got Professor Grzegorz Sobieszek from Poland, who's the head of cardiology and the cath lab at the First Military Clinic in Lublin in Poland. We've then got Dr. Kudret Keskin from Turkey, who's a cardiologist and interventional cardiologist specializing in CTO, and Dr. Ankit Gupta, who's an assistant professor at the All India Institute of Medical Science. So without further ado, I'm just going to introduce the first presentation, which is by Dr. Sobieszek on the topic of an uncrossable lesion in CTO-PCI. Over to you. Thank you very much.
Thank you very much. Thank you very much for the invitation. Good morning for everybody. So I start with my presentation. So I'd like to present two CTO cases. I hope it will be quite educational cases. So the first case is uncrossable lesion in chronic total occlusion PCI. So this is the clinical presentation of the patient, 67 years old male patient with CCS class 2, post-myocardial infarction, post-PCI LAD, optus marginal, instant stenosis in LAD with good ejection fraction, and only hypokinesis on inferior wall. And in angio, we had a mid-right coronary artery chronic total occlusion with calcifications with antegrade collateral flow and retrograde flow, mostly from epicardial, collateral from circumflex. So in JCTO scored 2 points, and it was looking rather simple case with a big probability of antegrade wiring success. And exactly, antegrade wiring was successful. However, the biggest problem in this PCI was uncrossable lesion in distal right coronary artery, and we could not progress with smallest alveol 0.75, as well as microcatheter Corsair Pro. So after prioritization of PROX right coronary artery and use of guide catheter extension, we still could not progress with torus or rotor wire. So for us, the best option in this situation was use of granuloplasty with small balloon, as you can see here. And after this, the alveol 0.75 balloon passed, and this is the prenotation and the final result. So in conclusions, 0.75 smallest alveolar balloon is very valuable option in uncrossable lesion. Of course, there are other options like better support, like anchor guide extension use, Of course, the use of rotablation or orbital atherectomy, if we can pass with rota wire or viper wire or exchange with use of microcatheter for these wires. However, better option in uncrossable lesion, of course, is rotablation. Use of microcatheters, especially Tornus or Turnpike Gold, use of external crash, and possible use of external lithotripsy in uncrossable lesion. And granuloplasty is rarely used, but quite effective technique for treatment of uncrossable lesion that we could remember if we have problem like I had. The second case, it's a 78 years old male with CCS class 2 post PCI left main LAD or circumflex with chronic kidney disease and with good ejection fraction and only hypokinesis of basal segment of inferior wall. And in angio, we had prox right coronary artery chronic total occlusion with blunt proximal cap with calcifications with antegrade collateral flow and retrograde flow mostly through two epicardials, one from circumflex and one from LAD, not to visible septal connection. So in JCTO score 3 points. And antegrade wiring was not effective, probably due to massive calcifications we can see. So we changed strategy for ADR, we form knuckle and then progress the knuckle. And use the stingray balloon. Sometimes we are using recross. Sometimes we started with wire-based antegrade dissection and re-entry using, first of all, Gladius MG as a first try, short try, not to progress hematoma. And even several attempts of performing stick and drive technique, ADR, was not effective. So we changed strategy, totally untypical for the strategy technique that is normally used as a bailout technique, antegrade fenestration re-entry. So balloon and another system of wire that should go after ballooning to connect spaces and finish in true lumen. And for the moment, we're almost sure that we are in the distal true lumen, but we checked IBUS and it was not. So we changed strategy for retrograde septal collateral, but it was not effective as well. And then we go epicardial. Very easy, very fast. Even it was teeny epicardial, it was rather not tortuous, as we can see. And then very easy true-to-true wiring with retrograde wire to guide extension. And when we are using epicardial collateral, sometimes better option not to progress with teeny epicardial collaterals and risk of perforation with retrograde microcatheter, but safer options tip in. So antegrade microcatheter on retrograde wire, then exchange the wire and wiring the vessel with antegrade wire. And predilatation and the final result. So in CTO, in conclusion, we have sometimes many different options, but sometimes the option that normally is regarded as most risky, like epicardial collaterals and risk of ischemia or perforation, is the easiest way. Thank you very much for your attention.
Thank you very much for the excellent cases. And regarding first case, that was, as you presume, probably easy enter case, but also I can comment in our everyday practice, we more and more encounter with the cases of so-called uncrossable lesions. So you cross with the wire, you cross, but uncrossable lesions are really big problem, especially when you don't have a microcatheter through. So sometimes the wedge, small profile tapered microcatheter can help to propagate a root of wire through. Like we have very small, unique tapered microcatheter today. The Caravel was the first for Serco XS, and then we have also Pronavi 1.9, which is very thin. And you manage it. But first of all, before ROTA, we always do with ultra small profile balloons, and today we already have excellent choice of ultra small profile balloons. And as you showed, you used Alveo HP 0.75. That balloon indeed has the smallest tip crossing profile. It's below 0.16 inch tip, and also the smallest crossing profile with all semi-compliant balloons. So it is, in my opinion, also a very good option for uncrossable lesions, especially with hard support, Amplatz guide extension support, and you manage it very well. Regarding second case, also great case. You tried after the knuckle, I see also you tried the bobsled technique with changing of the position of the stingray balloon. After that, anterior administration and re-entry technique. Recently, modification of that technique called SAFER has been presented from Mauro Carlino on CTO and also at the Swiss CTO. They had a live case. Unfortunately, not. They had a lot of hematoma. I have to say, I published recently some wire-based technique, which is called SSDR. It can be found on the Cardiology Journal, and we started collecting the patients, and we see the natural evolution of the CTO-PCI when you used all the hybrid techniques. It's an amazing case. Septals, in my opinion, were not so promising, but also epicardial was promising. So you used also tapered ultra thin profile microcatheter, which is historically been used also Caravel. Maybe you use Pronavi 1.9 here, which is also very thin, and the proximal shaft is 0.1 inch thinner. Even Pronavi 1.9 is 0.1 inch thinner than Caravel, and you managed to cross it through. So also regarding tip, I completely agree regarding tip in. Especially tip in the experienced hands is really not, or around the room and over is really not complex to do. And also we are developing some maybe techniques, and it crossed my mind recently. Somebody did a balloon assisted tip in. You know, when you don't have a wire, you don't have, and you compress with a balloon. Enter with microcatheter to prevent the wire goes around the microcatheter. And I had the idea recently that I have to try. So maybe we can try the POT NC assisted, POT NC balloon assisted, because it doesn't have long shoulders, so the wire doesn't have to the pocket. So maybe POT NC balloon is ideal balloon for balloon assisted tip in. So. A lot of ideas coming from these cases. So thank you very much again.
Thank you very much. Thank you very much for your remarks. I totally agree. Very nice technique with balloon assisted tip-in. Yes, and for me, the last case may be educational because, of course, somebody can ask, why not, of course, after antegrade wiring first try, why not to go first with epicardial? I think sometimes we must think about this way.
I agree. This is the last resort in most hands. So, but it's feasible when of course you have to be ready for preparation for coiling from the both sides. It needs additional caution. Any comments from Dr. De Silva? You're muted.
Great cases. I was just going to ask you, Grzegorz, with the first case, when you use granuloplasty, if that failed, if you failed to cross, obviously the Alveo is an excellent balloon with its low profile, but if you're unable to cross at that point, what would your strategy have been? Mihajlo mentioned the use of microcatheters, deep-seated microcatheters, and trying to get a rotor wire. Would that have been your next move, or what else would you have used?
Thank you for the question. Great question. I think it's an educational case because you can see many steps many strategies we can use in an uncrossable lesion. And the next step of me will be external crash. I know it's a little controversial method, but I had experience with some cases and it was successful. So probably it will be external crash. However, in this artery that is not too big diameter, it can be a problem of hematoma and losing the true lumen and visualization.
And in regards to the second case, antegrade fenestrated re-entry has, become a more novel, newer way of re-entering, often as a bailout. How often do you use it in your practice? And when in your sort of hybrid algorithm do you bring that in? Is it genuine last resort, or are you bringing it in more early in your ADR cases?
Very good question as well. So my answer is very rarely, to say the truth. This is rather last bailout technique, maybe, and I'm not using it too often. And to say the truth, I don't see so big efficiency of this technique.
Excellent. I don't believe we've got any questions from the audience. Any questions or comments from the other speakers?
Well, I would like to make a comment. Hello. I would like to make a comment with respect to the antegrade fenestration technique. As Mr. Kovacic pointed out earlier, there's a newer method that was published recently by Caro Di Mario, the safer technique. It seems to me that it's a better technique for that. You advance a balloon distally, and then you use a 1-to-1 size balloon, and then make several fenestrations, big fenestrations, through which you can advance your wire more easily to the distally. To me, it looks like more promising. What do you think?
Yeah, just a little lapsus correction. It was Mauro Carlino. So they tried a live case on recently one of the meetings. So it's like modification of AFR when you balloon at the level of the distal cap and on the proximal level of the distal true lumen with the one balloon. The idea is to make several connections that you release that hematoma into the distal true lumen, but in real practice, it's not. They had some cases which they were successful, but in the real practice, it seems that it's also not so easy. And we were witnesses of developing of huge hematoma up to the Cox level. So eventually, they did make some fenestrations and they finished the job. But the hematoma problem is here also the main issue, I think, in the AFR and safer techniques. And the great addition in my practice is to have straw technique is a little bit bulky and I'm not using, but we have, for example, if I'm a user also of recross device, great when we have big hematoma, extra alumina, extra black space, you can put a recross device in there. And I did some cases when recross has blue and the white ports. And you see where your wire is going up or down. You can change port, and on the opposite port you connect the indeflator to the negative pressure. So you have so-called power straw, continuously negative pressure of the hematoma while you're trying to poke with the wire on the different port of the recross. So actually recross also can be used like ADR dedicated device, and it really is dividing wires in opposite sides and in the real time power straw technique, so it can be helpful also.
So I totally agree. I'm using recross in ADR technique as well, and I think what you said that continuous straw technique is really nice thing to have still distal visualization. Another thing in recross that is really simple in comparison with stingray preparation and exchange of wire. So we can use recross for parallel wire technique, and then change strategy for knuckle ADR and use the same recross for ADR. However, it's maybe not so efficient because of the shape of the stingray balloon. It's not so maybe efficient as a stingray, but we can just start and try. And about anti-grid fenestration and re-entry technique, I think the place still will be before investment, as maybe bailout technique can try.
We've got a question from the audience, which is great. What's the success rate? This is a question that's been context with, I've got a beginner question. What's the success rate of CTO-PCI overall? So, I mean, I think I can start with this, and perhaps my colleagues will add to the question and answer. It varies depending on experience. I think that's the first thing to say. And it also varies on your ability to be able to switch from different techniques. So if you only are able to work in the antegrade setting versus both antegrade and retrograde, then your success rate is going to be much reduced, and therefore developing skills to allow you to cross between antegrade and retrograde, as shown in the first and second, the second case by Grzegorz, is really key to increase your options and increase the success rate. And I think most contemporary literature now would suggest when you're able to sort of complete hybrid CTO procedures, your success rate's in excess of 85 or 90%. But very happy to hear what my colleagues have to say about that.
Yeah, I agree with that. For example, the second case from Gregor, if you can do all this, you can call yourself complex hybrid CTO operator. If you do only CTO antegrade, like easier cases, like majority of the people do, in my opinion, they are not complete CTO operators. If you do complete hybrid algorithms, you know all the materials, all the techniques. In Euro CTO club registry, there is a now success rate about 89 to 90%, and we can achieve about 85, 90, even 95%. Of course, if sometimes in my practice, not to avoid complications, my personal success rate now is 90% in the Euro CTO registry, but I'm also not forcing to the bones, like said, because sometimes I make or investment or I stop. I make better strategy for the next time. I'm not willing to push post-cabbage patients in epicardials to open the small vessel. So we have to be very careful and have whole patient in perspective. But overall, quick answer is about 85 to 95% average is today in expert operators.
I think very important in success rate is one thing is, as you are telling, the operator experience. However, another thing we must tell is that we must think, of course, about cases we are doing. And if you are working in a reference center and we are performing cases that with 1, 2, or 3 failure attempts before, and really difficult cases, of course, the success rate will be sky high when it's normal, So it's really hard to sometimes measure the success rate, because we can have, of course, 80, some centers with 80 or 90% antegrade wiring cases, and then other centers with 50% doing retrograde or ADR cases. So I think this is clue.
That's important. That's a good point. So just in risk of losing time, I'm just going to move on to the second presentation. So thank you for that initial talk. The next speaker is Dr. Kudret from Turkey. So he's going to be talking on the microcatheter of choice in CTO and complex core interventions. Over to you.
Hello. I'm now sharing my screen. Can you see the slides?
Yes, we can.
All right. First of all, I'm really glad to be here with you. And today I'm going to talk about the microcatheter choice in CTO cases and where actually does Pronavi microcatheter fit into. First of all, why do we use microcatheters? Well, there are several reasons why we use microcatheters. First and foremost, the most important thing is to increase support and stiffen the guide wire tip. And in CTO cases, we need a lot of support. So microcatheter is a must in CTO procedures. And beyond that, we can also use them for enhanced guide wire steering, allow safe and efficient guide wire escalation, de-escalation, reshaping as we go through the lesion, secure distal access wire exchange, contrast injection, drug delivery, and collateral channels dilatation, protect collaterals from wire restoration, and redirect wires as we use in dual-luminal angulated microcatheters. So there are a lot of ways we can use microcatheters, but basically to increase support in CTO lesions. As you can see, there are so many catheters available in the market. So which one are we going to use? Are they all the same? What are the features of each microcatheter? Well, for a general idea, there are some classifications, and it's a very classical classification. There are some big microcatheters, and there are some small microcatheters. Briefly, I will talk about why they are big and why they are small. And there are the angulated ones for example, side branch crossing or parallel wire technique or whatever. And dual-lumen microcatheters, they are also commonly used both in CTO and or other complex lesions. And there are the plaque modification. There are microcatheters that are really big and bulky that are used for plaque modification. So each type has a specific indication. If we examine a microcatheter, for example, this is a fine cross, one of the oldest microcatheters available on the market. There is a PTFE inner layer. It's plastic tube, basically, onto which a stainless steel braided mesh is mounted, which gives pushability and some resistance so that you can advance it through angulated lesions. If we look at it closely, you can see the stainless steel braid mounted on the plastic material, which is called PTFE. And it's the most basic type of microcatheter. However, if you cover them with more coils, let's say inner coils, outer coils, this is from Pike. Of course, you have better support and better torqueability. Once you start torquing, you have a better chance to transmit the torque to the distal tip. And the catheter, of course, microcatheter becomes stronger, but there's a price to pay. And that price is the diameter of the microcatheter gets bigger, and it may not be suitable in all circumstances. And finally, there is a polymer layer on the top of the microcatheter, a slippery material, lubricious material, so that you can navigate through tortuous and calcified lesions. You can even be stronger. This is from Pike gold. There's a screw-like pattern in the distal tip. The threaded design. It's very bulky. Basically, these types of microcatheters are being used for debulking and calcium modification in such severe cases. But it's big, so you cannot use it in every way. Another type of classification based on these designs, maybe we can say that there are torqueable and non-torqueable microcatheters. If you have coils wrapped around the braided mesh, then it's better to torque it. But if you don't have such a coils, no matter however you torque it, you cannot transmit the torque to the distal tip, and you may not advance it. So torqueable and non-torqueable torqueable and non-torqueable catheters are really different from each other. And this is a general design spectrum of microcatheters. It's a summary slide, actually. You know, at one hand, on the right side, you have tournament and profile gold, which are really heavy and threaded delivery. And on the left side, there are some slim microcatheters with a low profile and general use. So, in this context, where does Pronavi fit into? I would like to now go into this in detail. So, Pronavi microcatheter was manufactured by BrosMed, and there are two types actually: 1.7 French and 1.9 French. 1.7 French is a blunt tip and is a balanced tip with small profile, achieves easy navigation on tortuous and complex anatomy. The other one is 1.9 French. It's a tapered tip, as you can see. The tapered softened tip with tungsten powder provides exceptional visibility, durability, and pushability through tight calcified lesions. Actually, 1.9 French has coils around it, so it's more better torqueable than the 1.7 French. That's why it's bulky. If you look at the catheter inner body construction, there's a similar design. The PTFE liner inside, and it was covered with a braiding in the 1.7 French design, which gives it a kink resistance and control and trackability, and of course pushability. You can also do super-selective injection and support, providing guide wire support, and you can find channels more easily. And this is the tip entry profile compared with its competitors. As you can see, Pronavi 1.9 French has a 0.019 inch tip entry profile due to its tapered design. So it gives great advantage in very calcified tight lesions. In terms of flexibility, again, compared with its competitors, we can see that the tip flexibility is enhanced in Pronavi. It's quite good, and the pushability is, of course, is again better compared with competitors. This is an overview of the features of several microcatheters available in the market. One of the things that I would like to point out here is that if you are navigating through very tortuous and long lesions and saphenous vein graft lesions, you may need longer microcatheters, and in that sense, Pronavi offers a 162 centimeters long microcatheter, and it may be used in certain circumstances. And the profile is really low, and it's really suitable for, especially for epicardial crossing. Now, I would like to present a few cases where we used Pronavi. This is a LED CTO case. You can see the CTO right after the first septal branch. It's a relatively short CTO and with a JCTO score of 1. So we thought that it was a really straightforward case with an anti-wire escalation strategy. We can cross the lesion. However, later it turned out to be that was not the case. So with the Navigating microcatheter and field XDA, we tried to pass through the lesion and through to through, but we ended up in the subintimal space. And then we switched to the parallel wire technique with a Gaia second. However, as you can see in the right picture, we were not in the wire vasculature. And then we searched for septal collaterals. First we tried to go from septal to septal, but it was not really suitable. And then we switched to retrograde. We had a tip injection from the right distal, but coronary distally, and then we saw some channels, but somehow we did not succeed to pass through these septal collaterals. And then, as a last resort, we checked the obtuse marginal, and we saw that there were epicardials, very tortuous epicardials going into the distal LAD, the apex. And we passed, we passed the cyan black from distally into the LAD. And This is a fast-forward view, but you can see the Pronavi 162 microcatheter 1.7 French went relatively easy into the distal LAD, and then we had a wire exchange. We take the Gladius EX, and then I don't want to go into the details of every step procedure, but we applied a reverse card. And then, since this was an ipsilateral collateral, either we had to use the pick-box method for externalization or tip-in, but in this case, we used the tip-in, and the wire exchange was successfully done. And the final image, we analyzed the CTO. So this case really illustrates the Pronavi in a part where tortuous epicardial collateral passage, and it really worked in this case. And the other case that I would like to present here is that a very long CTO lesion in the right coronary artery. We calculate JCTO score as 5. This was a really hard case, a long CTO lesion. There were some good collaterals from the LAD, septal collaterals. There were so many. First, since the distal septal seems to have a nice connection with the distal RCA, we used a Superforce 120 angulated microcatheter, and we tried to advance the fielder FC into the distal RCA. Although we managed to deliver the wire, it was very angulated, and the microcatheter did not follow, and we lost wire position. So we gave up that septals, and we went to the second septal. We had a tip injection, but as you can see, it was not really promising. So we went even back to the first septal, and we made a tip injection. There seems to be a connection. So we advanced the SO03, and we somehow we were lucky to reach the distal. This is the septal crossing. We had a hard time, but we somehow managed to reach the distal RCA, the distal cap. But as you will see in a second, on the right slide, on the right picture, the alone microcatheter could not advance. However, we tried, because of backup issues maybe, we could not advance the alone microcatheter. That's why we exchanged it with Pronavi 150, 1.7 French, and as you can see, it advanced pretty smoothly without any resistance. And later we redirected the wire to the distal RCA and to the distal cap, and then took a Gladius. Actually, we were not able to go into the guiding, so we went into the aorta. After successful snaring, we do the reverse card, and the final image was satisfactory. So these are two cases where we used the Pronavi successfully, both in septals, where angulated septals, and where other microcatheters could not advance, and one in the epicardial. So, in summary, I can say that collateral crossing, either septal or epicardial, requires low-profile atraumatic hydrophilic microcatheters. In that sense, Pronavi 1.7 French or 1.9 French may be an option in such tough cases. Thank you.
Sorry, thank you very much, Dr. Keskin, for the great presentation and for the talks. Nice overview of the available microcatheters. And just a quick comment regarding first case. That was very nice presentation of ipsilateral single guiding retrograde CTO-PCI. Usually those kind of epicardial collaterals My wire choice is a Suo 03, but in careful hands, you showed you could actually cross it with the C on black. Of course, we have a lot of ultra low profile microcatheters available, and you show that the utilization of the Pronavi microcatheter. In my practice, I usually choose the 1.9 taper tip because it has soft taper tip and it's a little bit bulkier for retrograde ipsilateral, but also very thin. But again, 1.7 French is ultra low profile, even lower profile than fine cross. It's perfectly safe for these kind of maneuvers. Main advantages, in my opinion, in comparison to some other microcatheters on the market, is length of the available microcatheters today. In long epicardial or long septoepicardial dual guiding or ipsilateral, we need to have sometimes short retrograde guiding because the microcatheter isn't long enough to go for the externalization. And today we fortunately have available these very long microcatheters which are developed for the retrograde very long, like Pronavi 162 centimeters, which is a nice addition. We don't have to shorten our guidance. We don't have to use 90 centimeter guides anymore because we have those microcatheters. Also, very beneficial of those design of modern microcatheters that proximal shaft diameter of Pronavi both is 2.5 French, and we can put two microcatheters simultaneously, very easy in 7 French guiding. To do tip in, so no need for ping pong, and ipsilateral single guiding complex procedures are now possible with those microcatheters, especially when we have like this around the apex very long epicardial. So we have to. It's a very nice addition to have a small profile microcatheter and very long, like 162. To be honest, a little bit joke. I don't know why 162. Why isn't 160? It's very. We have Elong, which is 170 also available, but the tip of the Pronavi is a little bit softer than the tip of Caravel, and maybe in theory more safe in these thoracic epicardials. But these are my focus on this microcatheter technology.
I was just going to add, great presentation, great cases. You went through very clearly that the variety of different microcatheters available to us and to the members of the audience. I guess collectively, how many different microcatheters do you think we should be having to complete varying complexity of cases? So, in our toolbox, should we have 2 or 3 with different properties, or do you have a larger array? What's your personal practice? It'd be interesting to get the views of the speakers as well as Mihajlo as well. Maybe Grzegorz starts and then Ankit after that.
So I think, as you said, 2 or 3 are necessary for different techniques. Of course, 1 microcatheter for calcifications, 1 just base for just simple antegrade wiring, and of course for septal collaterals and for epicardial collaterals, a microcatheter like Pronavi or like Caravel. The one thing about second case, sometimes if we cannot pass the septal collaterals, I use the daughter technique with shorter microcatheter, and then we have a channel after this, and we can use the longer microcatheter. But to say the truth, in my experience in my cath lab, I have 5 or 6 because I like to try some new things. But I think the 3 are enough for different techniques.
Ankit, what about from your experience in India where you practice?
I usually take the fine cross for the antegrade whenever you do the antegrade approach CTO. So I usually take the or maybe sometimes crusade when angulated whenever there is a hostile CTO, and the retrograde I used to take the that Corsair Pro. Mostly in my experience, I usually have done anti-grade approach with if you have a good skill and a good approach during the anti-grade approach, then you can easily go through the case by even by the fine cross also.
And Mihajlo, with all your experience and knowledge about various bits of equipment, what would your advice be to someone setting up a CTO service in terms of basic microcatheters that you should have in your toolbox?
In the majority of talks about microcatheters, there's always mentioned that we need at least 3 microcatheters. You know, we need a more strong one, a very thin one, or some modified microcatheter like turnpike spiral torus or something like that. In my practice, I also think like Gregor, I have at least 5 or 6 different because antegrade microcatheters which are very strong, for example, like of course a pro regular turnpike spiral when you need very strong support digging into the plaque. But also we have, for example, Boston Mamba, which is completely different design. You can spin it in the calcium, you can use it with a slow boss technique, so very different. Also for the retrograde, mostly turnpike spiral, Corsair Pro XS. Mamba microcatheter is not so good for the retrograde, and for the small channel, the second case for Dr. Keskin was typical case when the bulkier microcatheter, even though it was 1.9, when it doesn't cross, one of the option of uncrossable collaterals is that you grab. Of course, we know all the techniques, but one of the techniques is that you grab a smaller profile microcatheter, and he took 1.7 French Pronavi which went easily. So, but even though we believe that epicardial should be crossed with small profile, in the history that was always Carroll or fine cross, but we have now all others. It has to be mentioned that most of the epicardial collaterals can be safely crossed even with bulky microcatheter. Turnpike LP, which is okay, it is not bulky, it's 2.2 French Corsair Pro, but regular Corsair Pro, they can be crossed, and in most cases it is safe. But we usually in epicardial tortuous epicardials we use smaller like Pronavi 1.9, 1.6, Elon Caravan. Regarding microcatheter, we have a question from the audience. Is there a new microcatheter design you would like to have? For example, clinical challenge that current designs no address. We practically have all the designs today, but they are developing. For example, in my opinion, turnpike spiral is amazing microcatheter, but the rubbery tip is too long. You need a lot of space to wedge the coils inside the plaque. In some cases the rubbery band is too long. So if they shorten it, it would be advantage. So maybe I was thinking if they can design the microcatheter like a Gaia Next wire has properties, coil is X-strand coil actually, so you cannot destroy this X-strand coil there, and so on. But I think that today, unfortunately, we have a broad spectrum of microcatheters. We can deal with most cases.
Yeah, totally agree. I think that one of the things, just to say that's been a great addition, is the elongated sort of catheters, the ones that are 162 centimeters, 170, as you say, to not need to use a shorter guide from the retrograde approach. So that's definitely a great addition to the more recent microcatheters. Okay, great. I think we'll move on as we're just starting to go behind time, and it will be.
Yeah. Now the speaker for the next talk will be Dr. De Silva, and his talk will be navigating calcium in complex lesions.
Great, thank you. Again, thanks for the invite from BrosMed, and hopefully this is a useful webinar. I'm going to just hopefully run through the basic principles from my point of view of navigating calcium in complex, and the same applies for CTO lesions. We know that calcific coronary disease is a common and growing issue. Risk factors for who develops more calcified coronary arteries includes the more elderly, those with diabetes, those with renal failure, hypertension, and smokers. Also, a new paradigm has occurred with the envelope of PCI increasing to involve a much broader, high-risk group of patients, including those, for example, who are having TAVI, which has opened windows into coronary disease that perhaps a few years ago we weren't treating. The effect of calcification on outcomes is very clear, and this is data that's been evident for a long time. Those with severe calcification have a definite disadvantage on all counts, including death and myocardial infarction. So this is something to be taken seriously, and for something that we need to really try and improve our procedural technique to improve our longer term durability. So this is an interesting slide just showing that a simple metric such as the arc of calcium can define how good or bad our end result could be. And you can see that as the arc of calcium increases beyond 250 degrees, certainly there is a vast reduction in stent expansion. So we need to be cognizant of that and understand, how much calcification there is, what the arc of calcium there is, and that you really can't do on coronary angiography. It's intravascular imaging with either IVUS or OCT that will guide this kind of information. What are the aims of calcium modification? I've simplified it from my point of view to three things: to reduce or alter calcium burden, to change lesion or vessel compliance, and ultimately to increase the vessel lumen size to aid delivery of equipment. From an intracoronary imaging perspective, what are the markers of poor stent outcome? We know that if there is an arc of greater than 180 degrees, a lesion length that's calcified of more than 5 millimeters, and a depth of calcium more than 0.5 millimeters, these lesions tend to do less well from a stent expansion and therefore durability point of view. So this is something that when you're imaging an artery, you can routinely assess and look for to then guide your subsequent modification technique. So from a toolbox point of view, as we've touched on already this morning, there are a number of different devices available to us in terms of PCI generally, but from a calcium modification perspective, it's also grown over the last few years. We have traditional balloons, semi-compliant, non-compliant, and then we go into the specialty balloons that include what we've seen today: low profile crossing balloons like the Alveo HP, scoring balloons, cutting balloons, lithotripsy, and OPN. And then we go into the atherectomy devices: rotablation, orbital, and laser. From my point of view, I try and keep my calcium modification as systematic as possible. I try and use wherever possible, whenever possible, intracoronary imaging to guide what I do in terms of modification technique. I then try and categorize it according to mild, moderate, or severe. This is a figure from a paper that I was involved with a couple of years ago. And the idea here is if you see increasing degrees of calcification, it is very likely you're going to need either one or more of the more sort of complex calcium modification tools. And you shouldn't really fixate on just using one device. You may need one or two or even three devices to complete a case. The important thing, certainly from a learning perspective, is to re-image, to understand how that device is impacted on the lesion and the vessel, to then guide ongoing modification during your case. So I'm going to just present two quick cases. The first one's an 86-year-old that was initially undertaken by a colleague of mine, CCS class 3 angina and 3 medications, hypertensive smoker. He's in the main care of his wife, so he's very keen to get back to being physically active and mobile. He's had a previous balloon angioplasty around 30 years ago. So this is a EView guide that was taken by my colleague showing a calcific proximal LAD, which is got reduced flow in the distal vessel as a result of it. There's a very sort of valiant attempt on this initial procedure. You can see here on the left panel an anchor balloon in the circumflex with a microcatheter trying to be passed through the lesion, but it was uncrossable with both microcatheter and low profile balloons. The microcatheter was used to deliver a rotor floppy, but due to difficulties with guide support and subclavian tortuosity, the guide wasn't very amenable to undertaking rotor ablation. Actually, all of the equipment fell out at this point, and so the procedure was abandoned. And this is what the final image was at the end of the case. So no real change, no complications, which was important, but certainly no progress made on the first attempt. So I was involved with the second case. I undertook this via transfemoral 8 French just to increase guiding support, and used laser atherectomy as my upfront tool to allow me to utilize just my workhorse wire and to see if we could modify the lesion without using different wires and switching to rotor early on. The laser did progress, required multiple runs on 80-80 setting. I was then able to use the Alveo balloon to cross and further redilate the lesion. I wanted to image to try and understand what this looked like at this point, but I was unable to pass the OCT catheter, which defined in itself that we needed more modification. Unfortunately, larger balloons did not cross, and therefore I opted to switch to rotor ablation. So you can see it's becoming a very expensive case already using laser and now onto rotor. So this is the microcatheter sort of in the lesion, the wire placed, and then in the end, this required a lot of rotor ablation. It was around 9 minutes in the end of bear time, and this run on the right is the final, or one of the final runs, just showing the bear crossing. This was the OCT following laser, the low profile balloon and rotor. You can see in the sort of mid vessel coming shortly, there is very deep wall calcification. It's eccentric generally, but there are areas of more concentric calcification, which you can see coming up. Here's the lesion in its tightest, which was modified by the techniques that I've just spoken about. But you can see also that it's a long lesion with a lot of deep wall calcification. So we made progress, but certainly this was not sufficient to allow stent implantation at this stage. So I took balloons of the 3.0 NC balloon, which was wasted in the left panel, and I subsequently used IVL to modify this further, which resolved the wasting. And you can see here on the subsequent OCT, really interesting fractures that you often see with OCT, with disruption within the vessel, with intimal dissection, and fractures there evident in that segment of the OCT. So I was happier that the vessel was prepped properly to allow stent implantation at this point. So the final image here is a pre-PCI angio in the caudal view and post-PCI with 2 stents implanted. The left vein was optimized with a 5.5mm NC balloon. This was the final run. There was a bit of malapposition in the left main, but overall good expansion considering the degree of calcification within the case, and good apposition generally as well. Second case is a 68-year-old gentleman, slightly more acute. It was an out-of-hospital cardiac arrest with a 10-12 minute downtime, return of circulation with inferior ST depression on his ECG. He was transferred to the cath lab as a STEMI call around 11 p.m. So these cases occur all times of the day and night. The bedside echo showed moderate LV dysfunction post-arrest with an inferior regional wall motion abnormality. He was maintained in vasopressors on arrival with a blood pressure of 100 systolic. This is his right coronary artery. You can see in this panel there's calcification in the left system. And in fact, this gentleman had a mid-LAD CTO. And so this was essentially his last remaining vessel with a relatively small circumflex in the left system. So this is a really critically important artery for the patient. So you can see the calcification within the vessel wall and what looks like a fairly focal lesion, but a long length of disease within the angiogram on the two views observed here. While relatively easy with the C on blue, you can see wasting of a 2.5 millimeter semi-compliant balloon, and similarly a non-compliant balloon was used which ruptured. You can see just at the tail end of this clip the balloon rupturing. Unable to pass IVUS at this point, so it's balloon undilatable, and I elected to use rotablation, even though the acuity of the patient meant I wouldn't like to do this, but you have to do what you need to do in these situations. So a microcatheter was placed within the lesion, and a rotofloppy wire was passed distally, again relatively easily. A 1.5 millimeter burr was used to modify the lesion, and the final run shows the burr moving relatively freely through into the mid vessel. Subsequently, a 2.5 millimeter non-compliant did inflate both mid and proximal. Interestingly, there was still a lot of calcification, and IVUS was used to really define this in more detail. And you can see in the right panel the concentric nature of the calcification and a relatively deep wall calcification here. And I opted again just to ensure durability and a good stent result acutely to use lithotripsy to try and modify. Interestingly, a 3.5 millimeter IVL balloon ruptured after a couple of pulses. You can see the rupture here in the right panel, and that was after a 3 millimeter non-compliant was used to predilate further, which was also wasted. So I used a 3 millimeter. That failed, and the IVL unfortunately ruptured. From the IVUS that we'd already taken, you could understand the dimension of the vessel. So I used at this point a guide extension and a cutting balloon to see if this would make a difference. I used a 3.5 and a 4 millimeter cutting balloon to modify the vessel further. And you can see here, immediately following the cutting balloon, the proximal vessel, there are very clear fractures seen within the calcification, which meant that I felt this vessel and lesion was going to be more compliant. Identified the IVUS guidance for distal reference and proximal reference, and then implanted 2 stents with the assistance of the guide extension, 2 long stents optimized with post-ill balloons up to 4.5 millimeters. And this was the final result on the right compared to the original. And because of the use of IVUS, I was able to keep contrast relatively minimal as well, to 90 mils. In conclusion, coronary calcification is common and reduces PCI success and durability. Inadequately prepared lesions are analogous for stent thrombosis and restenosis. Calcification is important, as mentioned, and calcium toolbox needs to be utilized to modify calcium prior to stent implantation to really optimize our outcomes. And in my opinion, intracoronary imaging is critical in guiding how we undertake these procedures. Thank you.
Thank you very much, Dr. De Silva, for the great talk, and you really showed our everyday struggle in the cath lab today, because in my opinion, calcium is also the main issue in PCI today. We have a lot of tools. You showed the 2 very expensive cases.
Yeah. Quite expensive.
First case, when I saw the first case, I thought to myself, this is Photoshop case. But I never see before laser Photoshop case. So this is very interesting. We have a lot of tools, and we have to decide. I strongly agree with your conclusions with the imaging. So sometimes I personally decide between the rotablation and shockwave. The mostly about crossability of the devices. If I could if I have bulky calcium, which is mostly circular or semi-circular, but I can cross with some smaller balloons. We have also today very slippery, non-compliant balloons. I use shockwave, but when I have uncrossability mainly, so the rotor is first, and then maybe due to the cost, I combine rotor ablation with the OPN balloons. But sometimes, as you showed, rotor IVL is needed, and also other stuff, cutting balloons. In my opinion, scoring balloons due to the market are mostly for the softer lesions, maybe in-stent restenosis. For example, my strategy for in-stent restenosis is to have a scoring balloon to cut all the tissue, then to have an OPN balloon to squeeze all the tissue, and then to apply DCB. But for the calcified lesions, we really need to have, regarding balloons, ultra high pressure balloons and cotton balloons. But nice conclusions, and I agree with everything. So it's really calcium that struggles every day. Also, when we have CTO in very calcified lesions, we know it's gonna be power knuckle struggle with reverse card struggle and imaging guided. So thank you very much for the great talk.
Pleasure. Any other comments from colleagues?
Yes, I'd like to comment. Great talk and great cases, and very educational, especially one remark that we must now think about connection of different techniques in treating calcified lesions. Of course, very obvious is using together rotablation and rotatripsy. But the first case, really great case with use of laser to ease the way for rotablation. From my 20 years experience with rotablation, I have only 1 or 2 cases that rotablation did not pass. Sometimes I changed the bars and it was like 1 hour. But this case with use of laser, really great. And I think calcifications in chronic total occlusions are really underestimated. They are, as you said, Mihajlo, they are sometimes the biggest problem of a procedure. And my advice is, if we cannot go through, sometimes let's go beside. And in some cases with massive calcifications, I use knuckle and going extra plaque.
I was just saying, both of you, in regards to IVL and subintimal space modification, is that something you use commonly? Are you worried about perforation in that setting, or are you fairly confident that it's a safe technique?
I have no experience, to say the truth. I'm still waiting for my case, because I think it can really be a changing technique in these cases. So maybe for the next meeting, I will have something with IVL, subintimal or extra plaque. But from my experience, from some cases with external crash, sometimes it's very helpful.
The majority of the calcified reverse cards are actually beyond the calcium, not through. And IVL is, I think, amazing addition in our armamentarium for more contemporary PCI. Like external crash, I don't also have my personal cases, but very interesting concept if you have extremely hard uncrossable calcified proximal cap and you have a side branch, you park the IVL balloon and you put shocks, and maybe it can soften the proximal cap to change anatomy. So a lot of utilization. Regarding subintimal space in bench testing and in vivo testing, we know that shock waves only attack calcium, but for the soft tissue, they're harmless practically. So I believe they can, the IVL shocks can harm adhesion or make some perforation. And the also one discussion regarding shockwave balloons is I had also several ruptures, and any recommendations for you have to put all air out the area with the white connector or with the stopcock. But also, do you all inflate to the 4 atmospheres push off, then inflate another 1 or 2 atmospheres, and then deflate? somebody is saying that you don't need to inflate to the 6 and deflate. I don't know regarding shocks. What is your opinion?
I used to do that. I have to be honest. I don't think I do that routinely. I tend to just take it to the 6 and deflate. I don't tend to do 4 and 6 anymore, to be honest. And maybe that may be a reason why I sometimes get ruptures. I'm not really sure. I think a lot of the ruptures I've seen are due to sort of spiculated calcification that leads to the balloon just rupturing, but there may be another reason.
So I normally use 4 and then to 6 atmospheres, sometimes not, if I can see that the balloon is not developing, not inflating very well. And I think intravascular lithotripsy has another problem with lesions when we have in-stent restenosis, but we have not one layer of the stents, but for example 2 or 3 layers of the stents, and then it's not so efficient.
I will just add for the audience one my recently case regarding shockwave. I had one extremely uncrossable ring of calcium for the bigger balloon and for stents. I had an OPN undersized OPN 50 atmospheres, completely dog boned. After that, I waged the smallest IVL balloon inside, and the proximal marker was on the edge of this ring calcified. I applied 80 shocks, and even though the shockwave balloon was not inflated in that part, after that, obviously, the forces of the shocks are not only circular, but they can be perpendicular, at least in some small portion of the balloon. So I was able after that to expand it with the NC 2.5 and to place in bigger NCs to place the stent. So the shockwave balloon, these shocks are a little around of the balloon. So this is also.
That's interesting. That's a great tip. Yeah, I've never thought of that. That's really useful. Great. Okay. I'm going to just take us on to the final speaker, which is Dr. Ankit Gupta from India, talking on my balloon choice in complex CTO. Over to you.
Is it visible?
Yes, it is. Yeah. Go for it, Ankit.
A very good morning to all. It's a great pleasure to talk on my few CTO cases in front of legendary CTO masters from various countries. I'm going to discuss few of my recent cases. Here is a case of elderly diabetic hypertensive male presented us with non-ST elevation MI taken up for coronary angiogram. And just after the first injection, I was like, "Oh my God! It looks like an octopus. It's a single sinus with right and left circulation, very rare to find. Long left main running between the aorta and pulmonary artery, and RCA CTO. So I attempted this case with the antegrade approach and used the right sinus with the JR6 French, crossed the lesion with the filter XT by parallel wire technique, as we can see in the first angiogram, and try to progress the microcatheter beyond the lesion, but it failed. Thereafter, I took the mini trek 1.2, but it is still failed. Then I took the smallest balloon, 0.75 CTO balloon, and we can see in the third angiogram, it crossed easily because of its excellent profile and taper tip. And then I did the sequential pre-dilatation with the 0.75 balloon, as we can see in the first angiogram, followed by 2, 2.12 and 2.515 semi-compliant balloon. After exchanging the filter XT wire with the Sean blue and placed the 1 348 and post dilated with the high pressure with the 3 and 3.5 millimeter non-compliant balloon, and we can got the good result. We can see in the both the angios with the TIMI3 grade flow or the single sinus with left and right circulation. So there is another case of elderly male presented with multiple cardiovascular risk factors and with CCS, moderate with moderate LV systolic dysfunction, taken up for the angiogram. You can see that which revealed that LAD CTO filling retrogradely by RCA. I attempted this case by the antegrade approach. Left sinus hooked with extra backup 6 French, took the Sean over the fine cross microcatheter, as we can see in the first angio. Thereafter, I tried to cross the lesion with the filter XT. It was failed. Then I took Gaia first. It is again failed. Then I tried for the parallel wire technique with filter XT only, and able to cross the filter XT and parked it in the distal LAD. We can see in the third angiogram, it crosses the distal cap also with so after various efforts, after crossing the uh, filter XT again, but it could not progress. We could not progress the microcatheter. So I took the 075 CTO balloon, and it crosses the fibrocalcific lesion easily, and sequentially pre-dilated the distal to the ostial, and thereafter I took the sequential dilatation with the 1.5 semi-compliant balloon and exchanged the wire filter XT wire with the Sean. And took another 2 wires to secure the side branches, diagonal and the ramus. And again pre-dilated with the 2 and the 2.5 semi-compliant balloon. Took the shot to confirm the exit position of the wires. Then I took 2 DES 2.75 2.75 and 348 overlapped each other, both dilated with a 3 and 3.5, giving the good results with the TIMI3 grade flow. Here is the all the angiograms in the epicranial, allocranial, and the spider view. As we all know, CTO is not less than a depth of fusion. I would like to share few more cases of balloon uncrossable lesions. Here is a case of elderly male presented us last month only with acute decompensated heart failure. After stabilization, I took his coronary angiogram, which reveals RCA diffuse disease filling retrogradely from the left circulation. After crossing, the lesion was crossed with the filter XT. I tried to progress the fine cross, but it was not going. Then I tried 075 CTO balloon, but it was again filled. Then I put another wire in the side branch sinonodal artery with over a 2.8 balloon, giving a small inflation, and pushed the 075 balloon. And this 075 CTO balloon, which crossed the lesion successfully because of its good shaft design, and then I pre-dilated with the 075 and 2 and 2.5, and deployed the first stent 338 in the video to the mid RCA, and overlapped with the 3.548 after post dilated with the 3.5 NC balloons, giving good TB3 grade flow in the RCA. So here's another case of a 63-year-old female with various cardiovascular risk factors, presented us with angina. Her coronary angiogram showed LED CTO with diffuse disease on the RCA and the LCX. Is a mid CTO on the LED. So I successfully crossed the lesion with a filter XT, and but again failed to cross the microcatheter and even the 0.75 or CTO balloon. Then I took another wire in a side branch diagonal over a 2.8 semi-compliant balloon, gave a small inflation, and pushed a CTO balloon that easily crossed the lesion. As we can see in the first angiogram, because of its good pushability shaft of balloon. Then I did the pre-dilatation of with the 2 and 2.5 semi-compliant balloon, deployed the 3 into 48 drug-eluting stent, and post-dilated with 3.25 NC balloon. And here's the results we can see in the second and third angiogram, in the allocranial and the spider view. The purpose of discussing these few cases is basically to give the input in concern with complex CTO. Basically, the CTO balloons are not just are just very important due to taste the success, and so I prefer to have smallest CTO balloon in my cath. Thank you.
Thank you very much for sharing your experience and the cases. I have two questions regarding case one. I was wondering, due to the interarterial course of the left mains, you mentioned between aorta and the pulmonic artery and the CTO of RCA. What the heart team said about that patient? And what was the indication for the CTO?
Oh, yes. Actually, that case was indicated not heart teams. According to the heart team, it was the lesion was in the RCA. The indication that says if the left main is involved, then we need to go for the surgery. If there is a case of single sinus coronary single sinus with the left and right circulation, the left main in between the aorta and pulmonary artery, then it is definitely for the surgery only. But the lesion was basically on the RCA-CTO. So I attempted this case, and the heart team was said, okay, we can go for that, because whenever there is a tachycardia or anything, it is because the left main, long left main, is in between the aorta and the pulmonary artery. That is the reason we take these type of cases for the surgery if the left main is involved, or LAD.
I understand. I understood it at this between. So okay. And the second and last case, you have this case just to mention that long epicardial collateral is very good to have also in case of retrograde cases, long microcatheters and also small microcatheters to prevent ischemia of the donor vessel. And you showed your experience with, for sure, also low profile Alveo HP. Which other balloons do you use for uncrossable CTO lesions in your practice, and what do you suggest for the audience? And also for other members of the panel.
Basically, most of the cases in where I think it is whenever I perceive the wire while crossing the lesion, I think it gives some idea about the lesion, and moreover, I use some intracoronary imaging also, so that we can know about the basic morphology of the lesion, so that I can go through, because I have not shown the exact. I have done IVAS in these cases, and in this second case also IVAS, but I have not shown that. It is just to show the how I approached the case.
Question was, which balloons do you recommend for uncrossable lesions?
I prefer to have this 0.75 Alveo HP balloon whenever there is a uncrossable lesion, and if I have already shown that sometimes it also becomes difficult to cross the lesion whenever there is a fibrocalcific lesion. So we can take another other techniques also, proximal or balloon anchoring techniques, as I have already shown this in last two cases, that even 0.75 also was not crossable on those lesions. So basically,
can you stop sharing your screen just so we can get the members up on the panel?
It's fine now?
Yeah,
it's fine.
Thank you. Yeah.
Thank you very much. And opinions from the Silva and other members about balloons experience.
Yeah, great webinar. Thank you for everyone joining. I've been told that we've had more than 1,000 people viewing the webinar, so that's a fantastic audience. Hopefully it's been useful for everyone. We've gone through a number of different cases of varying complexity of CTO with a lot of contemporary techniques and devices, and I think the cases have highlighted the value of having and being aware of different devices. And if you haven't already read Dr. Kovacic's book, you should do. It's a real aid memoir of all the tools that you may need, and I think it's something that you should have on your bookshelf. But for me in London, thank you very much for the invitation, and thank you for the speakers for the great talks, and to Dr. Kovacic, thanks for being an excellent co-moderator.
Thank you, Dr. Silva, and
thank you.
Thank you very much for the co-moderating. Thank you, BrosMed, for
thank you, everyone,
and for all the members to present for the amazing presentation. And to conclude this webinar, like Dr. De Silva said, it was over 1,000 members of audience, so it was a successful webinar with a lot of teaching points. a lot of experience exchange, and yeah, this is all about it. So tools, webinars, and my key point is to make the learning curve more steeper. Really, we have to know techniques and materials, and the knowledge about materials is crucial, and also on that experience. So I have to just announce thank you again for the suggestion for my CTO Toolbox book, and I hope hopefully next year we will present a third edition, which will be even much better. So that all the drawings, all the pictures inside the book will be ours, and we will add additional chapter 60-70 CTO cheat techniques, all with high quality pictures, vectors, step by step. So and
Look forward to it.
passion and that. So
Excellent.
thank you very much for everyone.
We'll conclude there. Thanks to the speakers, and thank you to BrosMed, and bye from London.
Thank you very much. Thank you very
Thank
much
you.
for the
Thank
great
you.
meeting. Bye.
Bye bye.